Chapter 15, Prenatal Diagnostic Testing. Most women will have at least one fetal ultrasound during her pregnancy. They can detect movement, which includes fetal heart rate, movements, and breathing efforts. They've advanced over time to now have a 3D and 4D versions that look very lifelike. Most women are excited to have an ultrasound as it can confirm in her mind that the fetus is okay by seeing the heartbeat and the movements. It can put her mind at ease if she felt something was wrong, but the ultrasound shows that everything is okay. It can cause anxious feelings in these situations, so not every woman is excited to have the ultrasound. An ultrasound performed during the first trimester is often done transvaginally. It can detect the presence of pregnancy and location, if there is more than one fetus, can estimate gestational age, if it's a viable pregnancy, and it can detect certain anomalies. Ultrasounds done in the second and third trimesters are done transabdominally. During the second trimester, the woman usually needs a full bladder to displace the intestines to give a better view of the uterus. She must drink several glasses of water and not urinate until after the procedure. They are done during this trimesters for various reasons, including confirmation of a viable pregnancy, evaluating the anatomy of the fetus, estimated gestational age, check fetal growth, where is the placenta located, it should be at the top of the uterus, and where the umbilical cord is inserted. It can also tell which position the fetus is in. This is necessary if the baby is not in the head-down position, known as cephalic position, if it's close to the end of the pregnancy. It is also used if an amniocentesis is necessary to guide the needle placement. The advantage includes it is a safe procedure and allows visualization of the fetus in the uterus. The biggest disadvantage is that they don't always detect every problem. I have witnessed many times when anomalies are not caught on ultrasound and not known until birth. Alpha-fetoprotein is the main protein in fetal plasma and is excreted into the amniotic fluid. Some will cross the placental barrier and enter the maternal bloodstream. This means it can be tested via maternal blood sample or a sample of the amniotic fluid via an amniocentesis. An elevated amount of AFP can be correlated with serious fetal anomalies and requires further testing to confirm. As gestation progresses, levels increase, so the sample should be obtained between 16 and 18 weeks gestation. Multifetal pregnancies will have higher levels as well, and so can maternal obesity. This means that just because a positive result is obtained, it doesn't always mean there is a problem. Further testing is needed. Down syndrome is associated with low levels of AFP. The most common cause of the elevated AFP level is a neural tube defects, which can include spina bifida. When doing the maternal alpha-fetoprotein screening, known as the MSAFP, then only a small sample is needed. It is not very pricey, and it provides parents with information regarding status of the fetus, and decisions can be made if they will continue with the pregnancy. Limitations include it's just a tool, and many factors can cause false positives, which can cause worry to the parents. It can't detect all issues, and timing of the test is crucial for the most accurate results. Some women refuse a test as they know the results may not be accurate, and they have no intention of terminating the pregnancy no matter what the results will show. If abnormal results are obtained, an amniocentesis would be the next step to take. The multiple marker screening is where they are adding different markers to the AFP. These include HCG, esterol, and they help detect trisomy 18 and 21. A fourth marker is inhibin A and is more accurate in detecting trisomy 21 in women younger than 35 years of age. Chorionic villus sampling can be used to detect fetal chromosomal, metabolic, or DNA abnormalities between 10 and 13 weeks gestation. It can be done either transcervical, where a sample of the chorionic villi is aspirated, or via transabdominal, where a needle is inserted to collect chorionic tissue. It could cause heavy bleeding afterwards, and the woman is instructed to rest at home for several hours after the procedure. The advantages include the results are obtained quicker than an amniocentesis and is the preferred method during early gestation. Since results are obtained quicker, she has more time to decide if she wants to terminate the pregnancy. Of course, there are going to be limitations as well. There's over a 2% chance of pregnancy loss after the procedure. Also, limb reduction is another thing that can happen. This typically is a result of when the tissue sample is being obtained, it is taking tissue from the limb and causing it not to develop correctly. The risk of uterine infection is also there, although it's not a high risk. The possibility of fetal and maternal blood crossing is something to consider as well. This can cause issues if mom is Rh negative and the fetus is Rh positive. Amniocentesis is when a sample of amniotic fluid is aspirated from the amniotic sac. It is not performed as routinely in the first trimester due to some complications, and the chorionic villus sampling can be done with quicker results. The purpose for doing an amniocentesis during the second trimester is to examine the fetal cells in the amniotic fluid to identify chromosomal or biochemical abnormalities of the fetus. During the third trimester, the amniocentesis is performed to check lung maturity or to evaluate for hemolytic disease of the fetus, which we will talk about that more in detail in the upcoming weeks. When they are testing for lung maturity, they are doing this typically to see if it is better for the fetus to be born or to remain in utero. Some women have complications, and if the lungs are mature, then we can provide other measures such as fluids, nutrients, and oxygen to help the infant survive, so they will deliver the infant early. When obtaining the fluid for lung maturity, they are looking for the lecithin sphingomyelin, which is the LS ratio, to determine maturity. The lipoproteins that make up the surfactant. Remember, the surfactant is what keeps the lungs from collapsing. The ratio they look for is a 2-to-1, but sometimes this doesn't always mean they are mature enough, especially if the woman with diabetes, so they may also look at a couple of the phospholipids. To perform the procedure, the woman is in the supine position. Remember that pillow or wedge under her hip. They will place her on the fetal monitor to make sure baby is not having distress before, during, and after the procedure. They will use ultrasound to guide the needle into a large pocket of amniotic fluid that is not close to fetal parts or near the placenta. They will discard the first 1 to 2 mLs, and then about 20 mLs will be aspirated. They will continue to monitor for 30 to 60 minutes, and to determine no distress in the fetus is known and no uterine activity such as contractions are noted. She should avoid strenuous activities, but normal activity can resume in 24 hours. The advantages include it's relatively safe and a quick procedure and has a few reported complications. Disadvantages of the second trimester testing is the length of time it takes to obtain the results. Can be up to 2 weeks. There's a small risk to the fetus or umbilical cord and a small risk for infection. It also cannot guarantee 100% accurate results. This test may be harder for you to understand until you listen to the podcast on fetal monitoring. I recommend that you come back to this after you listen to that one so it makes more sense. It is done to detect an increase in the fetal heart rate with fetal movements, which indicates the fetus is receiving adequate oxygenation. This increase with movements is a good finding, and it's called an acceleration. An acceleration means that the heart rate increases by at least 15 beats above the baseline for at least 15 seconds. The woman is placed on the external fetal monitor known as the EFM. She can be sitting in a chair or in the bed. Sometimes a woman is given a marker she pushed every time she felt the baby move, but that marker is not needed. When interpreting, you are looking for the heart rate to increase at least 15 beats above the baseline for at least 15 seconds in 2 different episodes over a 20-minute period. This is called reactive or reassuring, and it's a good thing. The test can be extended for an additional 20 minutes since baby could have been sleeping during that initial time frame. A non-reactive or non-reassuring result is found if there are not 2 of those accelerations within the 40-minute period. This could indicate fetal hypoxia or acidosis, so further evaluation is needed. Advantages include it's non-invasive and painless, it doesn't take too long to complete, and the results are immediately available. Disadvantage is a false positive result can be obtained and unnecessary further evaluation. A contraction stress test, or CST, can also be known as the oxytocin challenge test, and it can be done if the non-stress test is non-reactive. They're trying to get the woman to have a few contractions to basically see if the fetus is going to tolerate labor. This should only be done when the woman is near full gestational age, has no complications, and no history of a C-section. The woman is placed on the EFM, and one of two ways can be used to stimulate contractions. The first is self-nipple stimulation. This is where the woman will stimulate her nipples by rolling them in her fingers. This will typically release the body's own oxytocin, which is what causes contractions. If this does not work, they can give her a dose of Pitocin, which is the synthetic version of oxytocin. Interpretation basically looks at if the fetus is tolerating labor. Are there any decelerations of the fetal heart rate? If not, the test is negative, which is a good thing. It means there's no uteroplacental insufficiency. I'm not going to require you to know more than that. Your book outlines more specific guidelines, but that is more information than you need to know for nursing school. Basically note that if there are signs that the baby is not tolerating the procedure, they will stop the test and discuss having a C-section. The CST is not used as often anymore since there are other options, but it does allow for further evaluation after the non-reactive, non-stress test. The disadvantages include it's more time-consuming than other tests, and the cost can be higher. A more accurate way to evaluate the fetal well-being is by doing a biophysical profile known as BPP. This looks at 5 different fetal areas. They include the non-stress test, fetal breathing movements, gross fetal movements, fetal tone, and the amniotic fluid volume. All but the NST parameter is obtained by an ultrasound. When performing the ultrasound, the tech will provide a score in those 4 categories ranging from 0 to 2 in each. When looking at these areas, it helps determine the fetal distress by the way of fetal hypoxia. If the fetus isn't getting enough oxygen, all the movements will begin to decline. When looking at the amniotic fluid level, they are looking to see if it is a normal amount. If the fetus is experiencing hypoxia, the fetus will send or shunt the oxygen to the vital organs, which for the fetus doesn't include the kidneys and the lungs. Remember, in fetal circulation, the lungs are bypassed, so they're not as vital right now. With less of that oxygenated blood reaching them, they cannot produce more amniotic fluid. The same is true for the kidneys. The decrease in the fluid will cause oligohydramnios, or low amniotic fluid. Table 15.1 shows the criteria for scoring in all the areas of the BPP. The last component is a non-stress test. A normal score is 8 to 10 for the whole BPP. Equivocal is 6 points, and abnormal is 4 or less. Anything less than 8 usually requires further evaluation. This can include to continue to monitor on the EFM. The lower the score, they will either plan to deliver now or possibly do further testing such as an amniocentesis to determine the lung maturity. The modified BPP is where they just do the ultrasound and not do the NST. If the score is low enough, then the NST really won't make a difference in what the plan would be. Moms can also assess fetal well-being by doing what is known as kick counts. Each provider is a little different on the guidelines they follow and the number they like to see. One may instruct mom to find a comfortable position and make sure she has eaten recently, is well hydrated, and has emptied her bladder. She then counts how many movements or kicks she feels in an hour. They range, and they like to see them about 5 to 10 in an hour. Other providers say that they want to see at least 10 movements over a 12-hour period. We educate and support whichever way her provider wants her to do. Advantages is easy to do, no cost, and non-invasive. Disadvantages include sometimes mom has a hard time determining movements, especially as a pregnancy progresses. The fetal rest periods can make it hard to determine, and some medications or drugs can reduce the amount of movements as well.